Welcome, everybody, to the Pelvic PT Rising free training for pelvic OTs and pelvic PTs and OTs and pelvic health. We've called it Rethinking Core Muscle Assessment and Pelvic Rehab. Let me give you a little bit of background to how this came to be. I was doing a lot of work on Pelvic PT Essentials, which for those of you who don't know, it is a signature course. It was one of the first courses I did. It is due for a major revamp. So I am completely revamping this. And as part of that course, I am doing a best practices on basically all parts of our exam. And I got to the core part and I was like, I am all over the place around this. I think as a group are all over the place around this. I've literally never onboarded anybody at my clinic that wasn't all over the place on this. And so it got me to be thinking like, what the heck? Why is this so difficult? And why is it so confusing and all the things? So I went down a deep rabbit hole on it. And I was like, this is just too important. I need to do this as a free training. And I put a question up in the Pelvic PT Huddle. And for those of you who don't know what that is, it's a Facebook group. There's over 13,000 pelvic PTs and OTs in there, all kind of like asking clinical questions. I make sure it's very clinical. And so I posted a question about core assessment, like what the heck are we all doing? And I got like 400 comments in like the span of not that long of a time. And everyone was doing something different and everybody was confused. And most of you guys ended up just writing core eval because you wanted to know what I had found. So that's where this free training was born. It is going to be part of a larger Pelvic PT Essentials course. So look out for that coming late spring, early summer. But here we are. And because there were so many of you then that signed up for this, it was like out of control, actually. We have over 2,500 people that signed up for it. I know that it was short notice and a lot of people were able to get on the live part of it, but it is going to be recorded. It's going to be available for a short period of time afterwards to re-watch it. So that's exciting. But because there's such a big number of people, I'm like, that I need to do a little reintroduction because I'm always really passionate about you guys knowing who you're learning from, right? Because I think that does, it's important for you guys to know like what biases we might have and all the things. So I am Dr. Nicole Cozean. I am a pelvic floor physical therapist, doctor of physical therapy. I also have my board certification in pelvic health. I am the owner and founder of Pelvic Sanity, Pelvic Health and Wellness. It's a brick and mortar cash-based pelvic PT practice in Orange County, California. We are hiring, by the way. So go ahead and reach out if you are interested in a job. But I'm also the founder of Pelvic PT Rising. So during COVID, we had to shut the clinic down. And we started the podcast, the Pelvic PT Rising podcast and Pelvic PT Rising. And we have a clinical arm and a business arm of that. We do business mentorship for people wanting to start cash pelvic PT OT practices. And we have clinical arm, which is I've got 4 courses and 3 master classes. I am the co-founder of Pelvicon, which is a huge conference in Atlanta for pelvic PTs and OTs. We do have a virtual piece of that. If you're interested in that, you can go to pelvicon.com. We have a symposium coming up as well. Pelvic PT Rising podcast, you guys, is such a passion project. It's so fun for Jesse and I to get on there and do that. It's over 1 million downloads now. I think it's 1.2 million downloads and counting. We've got over 600 episodes on there. We do a business and a clinical one. I wrote a book called The Interstitial Cystitis Solution. A little bit of an important distinction here is that I started my pelvic health journey treating chronic pelvic pain. And so I think that does influence how I treat a lot. A lot of my patients, especially at the beginning, were extremely complex and couldn't do a lot of stuff that a really active population had. And so I think that was also just really influenced how I treat. And I think it'll come through in some of this framework that we're going to teach today. I'm a wife and a business partner to Jessie Cozean, who is also the co-host of the podcast. Shout out to Jessie for doing all of the back end stuff and putting up with all of my procrastination tendencies. And I am a mom to Clay and Trevor. I am just trying to do all the things. Clay is 3, Trevor is just turned 1. And we're just trying to do it, y'all. We're all sick this week, except for me. And we're just trying to figure it all out. So that is who you're learning from. I am not necessarily, I'm going to tell you what I'm not. I'm not necessarily a exercise wizard or an exercise specialist, or, I have had my CSCS in the past and I let that shit lapse like a while ago. But I do think that movement and exercise prescription, especially, is very important in our field. I just think that we need to rethink how we're doing core assessments, especially after I dove into some of the research and stuff on how to do this. So I hope today you're going to find that the framework that I put forth to help us decide when it's important, what are we actually testing, and who does it apply to. I hope that that will be like the framework that you walk away with in this, however long it's going to be, hour-long training. So that sounds good to everybody. Let's go onward. I will be, if you have any questions, instead of doing like the actual question box thing, just put it in the chat and I'll try to go through. If I ignore your question, it is because I'm going to get to it in the presentation. All right, here we go. So I think when you all signed up for this free training, I asked you some questions, and basically a lot of questions were, does this all even really matter? And quite frankly, this is one of the things that I was really questioning as well. Like, do we even have an objective test that's objective enough for this to even really matter? Or are we all just kind of winging it and being like, yeah, kind of like your core needs a little work kind of vibe? And, so I feel like we're going to answer this question. Does this all really matter as we go through? But also in that questionnaire, 93% of you said, and of course, this isn't research based. I led this question a little bit. You all said that you wanted a better way to assess the core system. In so many words, most of you had said something to the effect that you don't feel like you have a clear, standardized, objective, and functional way to evaluate. I feel like we're adding on all of these qualifications. Like, if we're going to do it, we want it to be clear, we want it to be standardized, we want it to be objective, we want it to be functional, we want it to be perfect, essentially. And we need it to be that way because most of us are in a massive time crunch, whether that is one that we put on ourselves or one that was actually present in your guys' evaluation. So in the chat here, if you feel that you are like, gosh darn it, I don't even know what I do. Put it in the chat. If you think you do something different for every single patient, put me. If you're like, I'm confused what I'm supposed to do, put confused. Like, I want you to put the feeling that you have around core assessments here in this thing. And I feel like it's kind of, honestly, you guys, I feel like, thank you for saying that you're confused, because honestly, I feel feel bad about being confused about this. It's like, well, shouldn't we, if we're like rehabbing, if we're like rehab specialists, why are you confused about something that is so, and get this one, or Jesse would be proud of the pun, to our existence as pelvic rehab providers? And so you're not alone if you are confused. This is a good comment here. I always do the same thing, but it doesn't really seem functional or comprehensive. So I think we're going to hopefully address some of that. Yeah, almost a second thought, which is like, well, should it really be? And sometimes it might need to be. And so I think that that's an important thing too. Unsure about current best practice in the pelvic health realm. We're going to go into that. So here we go. So I was kind of reflecting on, like, why do we feel this way, right? Why do we feel like there's something really lacking? And I think that there's two main things here, because we're testing a system and not just a muscle. So I think that a lot of us, especially as PTs, were trained at like, oh, we do manual muscle testing for everything. And that's how we decide if something's weak or strong, right? And then that gives us, oh, your hamstrings are weak, we need to do a hamstring strengthening exercise. And then we just sort of roll it into being functional as we progress that exercise. But especially the core system. I would argue any muscle in our body is a part of a system and is dynamic and all the things, but especially the core. It's a system, it's dynamic, it's task specific, it's anticipatory. The system has a ton of functions. The system itself is complex. So I think that that's why we're feeling like a little bit confused, because the too long don't read version of this is that there is no one single core muscle strength assessment test that we can do that's going to give us all the information. And I think once we realize that and we come to grips with that, then we can decide, okay, well, what is, or what component is most important for us to be testing for this person with this diagnosis in front of us. But I think the second is that we were never taught a good framework. I mean, I don't know about you, and I know that I was in school a while ago, 20 years ago, almost to be exact. Pelvic sanity is 10 years old. I don't think that we were ever taught a good framework for this. I think that this is also glossed over for sure in PT school. And it's certainly, even if it was addressed in PT school, it was certainly like more orthopedic sports, right? You're strapping people to the table, asking them, do they do a prone lift, like a Bearing Sorensen test? Like, I feel like for a lot of our pelvic pain patients, first of all, some of them are pregnant. They can't even do that, first of all. Second of all, a lot of them, that's like just not the vibe. It's like, I'm not going to take somebody that has endo, quite frankly, and a million other things and MCAS and POTS and all this stuff and be like, you know what I think that you need to do right now is lay prone off this table, be half hanging off. I'm going to strap your legs down and like see how much you can hold up your back. It's like that doesn't fit with a lot of the patients that we're treating. And right. And it also feels outdated. But if we go into, and Daniela, thanks for making that comment, but that's really objective, right? And there's predictive value to that test and stuff like that. We're going to go into some of that later here, but we were never taught, I don't think, a good framework to do this. And we certainly didn't get it in our entry-level pelvic courses, because the system is complex and that we're just trying to get our heads around having to put our hand in or fingers in a vaginal canal or a anal canal. And so it's like, I feel like it always just gets pushed off, even though I think if we asked any single person as a pelvic PT or OT, we would say, oh my gosh, the core is so important. Right. And so those two things don't match. But I think we weren't taught a good framework. All right. We're going to say goodbye to our Instagram friends. And perfect. All right. So why are we lacking? It's because of those two things. Do we agree? Does someone agree in there? Want to see the perfect 1,000%, right? Perfect. So, but I will say this. I think the conclusion that we can't have with all of that is like, well, we weren't really taught that well, and I'm kind of winging it anyways, and my patients are getting better. So does it all really matter? And I'm going to argue in this that it does. The tests you choose matter, like a lot. And we're going to go into that now. So, but I do feel like we can get into a testing conundrum. And we see this sometimes in the medical example, right? We all know the research of if you get an X-ray and an MRI and you test something, you have it's unknown relevance, right? The test finds pathology, but it says nothing about the origin of symptoms. It might lead to unnecessary procedures and surgeries. There's usually worse outcomes after that. There's patient confusion and hyper-focus on, oh God, the X-ray was positive. I have it, or MRI was positive. I had a disc bulge at L3. And something is now wrong. And so, we have like an over emphasis on the positive findings, even though we have so much research to show that is not correlated to symptoms or anything like that, right? And sometimes what that does is it causes the clinician to shirk responsibility and just say, oh, you know what? Why don't you go see that guy that's going to do the surgery? Okay. So point is that testing randomly and testing without purpose can sometimes give us positive results, but they're not necessarily useful results, and sometimes even harmful to the point of taking our attention away. So that's a medical example of testing. That's a problem. The pelvic rehab example I'm going to give, and I argue for why this is so imperfect, the perfect test, in my course on pelvic PT, essential pelvic strengthening, not your mama's Kegels, is that even a test that we have that is supposed to be trying to test strength and function of the pelvic floor, we do a squeeze, we do a lift, we try to do it endurance, we try to do capacity, which is like the power that it squeezes with. We try to see how long it holds, we try to see how long it relaxes and all the things. But yet we know with research now that the weakness that we find on testing like that is not clearly defined. The findings aren't correlated to actual strength scores on like a dynamometer. So it's even a test that has positive findings, when used in isolation, can lead to hyperfocusing from a clinician standpoint on, that test is that strength is weak. Now we need to strengthen. And now that isn't the whole picture. Right. And so we hyperfocus on it. The patient hyperfocuses on it. And now we may be very far afield of what the real problem is with the treatment, or our time may be better spent in someplace else versus this area. So I have literally a whole course on what to do instead and all the things. But my point here is that just because we can test something doesn't mean we should test something. And I think we need to really take a look at what matters and why for this person. So we don't want to focus on one impairment. We don't want to miss the big picture. We don't want to have biased treatment plans. So we don't want to test the core and say it's weak and then therefore create a conclusion or a hypothesis that says, well, the core is weak because of this pelvic floor dysfunction, or worse, vice versa. And I think this happens a lot. And if you have been a person to do this, I will raise my hand first. I used to say and think that most of my patients had higher tension in their pelvic floor. And the reason for that increased tension, it was because of core weakness, right? Your core is weak. Therefore, your pelvic floor muscles are hanging on for dear life and trying to stabilize a system that is not stabilized. Has anybody used that phrase and rationale before? I sure have. Okay. And that's not wrong. So Eve, yeah, it's not necessarily wrong, but I think the assumption that we go to so quickly is that, right? And what I'm trying to get us to do with this free training today is rethink how we're categorizing those things and deciding when a core muscle evaluation and therefore treatment plan is more important to do early in the plan of care versus not. I don't think that anybody should leave our offices without at least a screen of their core function. And probably that incorporated into some of their movement and stuff like that. But I think where we can all use a lot of help is determining the relevance and how relevant is it and how thorough do we have to be based on the symptom presentation. And if we do this wrong, I think we get a loss of patient buy-in. Because let's say that somebody, just give you one quick example. Let's say somebody comes into our office and has primary complaint of painful intercourse. Okay, we've all had these patients, right? We have a tension pelvic floor. We have maybe a little bit of mild incontinence with it. We have history of low back pain, maybe a little bit of mild sciatica, right? We have all of this stuff. They come in though for primary focus of painful intercourse. We test their core. It's weak. And we test it however we test it. Sometimes we just look at somebody and assume and be like, well, you're probably weak because I palpated your transversus and it's not turning on right, whatever that means. And that's why, right? So what we need to do is we need to focus on your core. And if we focus on your core, then your pelvic floor muscle will have room to relax, right? And that might be the case, but we haven't tested well. And we forget that the patient came in with a sexual health concern. And now our primary focus is exercise, core, blah, 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 right? And Beth, why would the core be the go-to with painful sex? I'm talking about if you are trying to find the why, like I am always asking you guys to find the why, find the why, find the why. Why is the pelvic floor tight? It's not enough to just say the pelvic floor is tight. And I think sometimes what we do is we say the core is weak. That's why it's tight. And now all of our focus is on core strengthening. And the patient's like, when am I going to actually get some pain-free sex going on, right? And so I want us to, sometimes it just has a loss of patient buy-in, which I think is actually more damaging than doing the wrong test as well, right? So my goal for you today, the goal is not to find everything that's wrong or weak. but rather to find what is relevant and actionable. Daniela says that reasoning also gets complicated if the patient is someone who works on their abdominals so often, I love this, that they feel that their core is very strong and we have no testing to prove it, right? And we're going to get into all the different components of core strength here in a second. But my goal here today is to help you to find everything, not to find everything that's weak or wrong. And so not just test indiscriminately, but rather to find what is relevant and actionable, all right? So what are we actually testing, right? I know we know this. I have to put this in though, because otherwise I feel like I'm doing us a disservice, but the core is a system. It's made up of the diaphragm, the rectus, the obliques, the transversus, multifidus, pelvic floor. Some would even argue the glutes, the rectus spinae. Some would argue the psoas and all the fascia connections in and around that area. So it's a system. But isolated testing of any one of these muscle groups or even groups of muscles does not give a full core function picture. This is consistently complicating the stuff, right? The other thing that we know is that core muscles are neurologically linked, like the pelvic floor and transversus abdominis. So we can't dissociate those two things. We know it's a synergistic system. We know it can't be tested in isolation. And we know that it has a reactive anticipatory response, and it responds to intra-abdominal pressure and load. Okay, so that's what we know, and we know it's a system. So you can already see that this is why it gets complicated with testing, because there's not going to be one test that does all of these things. All right. So what we're really looking at, and I was reminded of this when I was looking at this. I think we would all get this on multiple choice, but I think we start to break down the components of what is actually most important for my patient. I think that this was good to review, right? So the three components of strength that matter the most is motor control, endurance, and capacity. It's like, what is happening? Forget my referee days. So motor control, endurance, capacity. All right. Motor control is timing and coordination, especially with load transfer or the ground reaction force coming up through the foot, or transfer from arm extremity motion down through the pelvis. All right. So test examples of this would be like the active straight leg raise test, the Starman progressions. And maybe if you've ever laid your person supine and had their arms interlocked, and then you're doing perturbations with their arms and seeing what their reaction is at their core, stuff like that. Right. Then there's endurance, there's sustained output and sustained contraction strength over time. These are things like plank holds, front or side plank holds. Okay. Relevant to some people, not relevant to others. These would also be basically that test the system, right? And then we have capacity. We have load tolerance. We have carries and squats with weights, either body weight or other, where we're actually having people carry things asymmetrically or whatever. And sometimes they're both, they're capacity and motor control. I would say things like the Institute of Physical Art, shout out to them. Vertical compression tests and elbow flexion tests are also a little bit of load tolerance, some of motor control. So that's a good test that does both, I think. They're same thing with straight leg raise tests, right? And so I think that we need to keep in mind that there are the three things that matter. And this is where it matters what your patient wants to get back to or what they are having problems with. All right. We're also going to talk about what we know with people with core strength and pain. So anybody that comes into our office that has pain, I'm talking low back pain, sacroiliac joint pain, pelvic girdle pain, all of that. And this is mostly from people of work like Paul Hodges, who's coming to Pelvicon, by the way, which is out of control. Diane Lee, the Hodges Lee stuff, all of the motor control literature that we have with people in low back pain and people in persistent pain. We know that they have altered motor control, loss of anticipatory strategies. Their anticipatory strategies become more reactive than anticipatory. It's not as simple as a muscle being weak, because some muscles are inhibited, but others become overactive. So that's just as important to observe and or test for in these patients. Low contraction and bracing might be a strategy that's increasing trunk stiffness, but it leads to decrease in movement variability, which we know is important for most all tasks and mental health. And then we have impaired proprioception and sensory integration. And the huge thing here is that these changes persist after the pain goes away. And we're going to remember that when we talk about what to do with these folks that are in pain later, because I think that's where it starts to become a little bit sometimes unclear about like how important is it for core strength to be focused on with somebody that has like IC, endo, even urinary urgency, something like that. All right. The other thing that we need to realize is that how does core strength change during pregnancy and postpartum? So people that have been pregnant or or postpartum have shown in the research to have altered motor control, changes in activation and timing and strength of their core muscles. It can lead to persistent pelvic girdle pain and low back pain if it wasn't present in the beginning. And if it was present, now we go back to the pain slide and show that it actually does alter a lot of that stuff anyway. We have seen differences in oblique muscle recruitment, namely bending of the external oblique and a increase grip strength or like activity of the external oblique. And stuff like that. So we have reduced transversus abdominal firing during load transfer. We have decreased diaphragmatic excursion that's been measured in pregnant people. We have changes to morphology and strength of the multifidus, so it actually gets thinner or less cross-sectional area, and therefore is weaker. And also, these people might have DRA or umbilical or a hernia or hiatal hernia that is also influencing the pressure management system of the core, right? And many of these things happen regardless of delivery type, right? So vaginal delivery versus C-section doesn't matter. All of these things happen. So we know this, right? Kind of a good summary slide of both of those things. And so how does that change? So again, you can also be like, well, now I feel overwhelmed, right? Does this all even really matter? And I'm telling you, yes, like a lot, but you could at this point be being like, the hell, now there's too many options. Now I really don't have time. And I wasn't testing anything like that at all, right? I wasn't testing the difference between capacity and motor control and load, right? And be like, maybe you could be confused, be like, what do you mean by motor control again? Like, how do I test the anticipatory system? And general feelings of annoyance, be like, whatever. I'm telling you that we can't just ignore this. Now we have to pay attention more. And now this is where the time comes in, right? So the time is 76% of you guys on that form said that you felt rushed on your evaluation despite you having 45 minutes to an hour. And I feel like 24% of you actually lied, because I don't know about you, but anybody that I've onboarded at Pelvic Sanity or mentored or anything like that has always had a problem with time management, especially on the eval, because we don't know what to prioritize, right? It's all what Pelvic PT Essentials is. So I do feel like this really should be 100%. And again, this isn't research-based. This is just my hunch. So there you go, right? Yes, the hill I'll die on. We don't have enough time, and we don't. Really. But here's where this gets good, you guys. And I promise you we're going to get to the nitty gritty of stuff. I promise. But hear me out, because we got to set this up well in order for things to sort of make sense. All right. Everybody with me? Say with me in the chat. We good to go? Some good reminders here. Perfect. All right. So clinical relevance, core strength testing. So I really, truly believe that if we can categorize people into a high clinically relevant state to do a bigger investigation on core muscle strength, or a lower clinical relevance, to move on with core strength testing. I feel like that's the best thing that we can do to help with our time management. All right. Because when you're unsure, you're either being like, never mind, I'm not going to test it, or and then you never get that information, or you are testing anyways and then now you get positive tests, and then we have the testing conundrum that we just talked about. So the key here is two things. Number one, realize that we need to start categorizing people and deciding for ourselves as the clinician, is this important or not important? All right now. And if it's important, we need to move it up in the plan of care. And if it's not as important or clinically relevant to that person sitting in front of you, then boom, it goes in the lower priority, and we could just let it go for a while. No one's going to die because we didn't test their core. All right. Now, in Pelvic PT Essentials, I introduced this topic of phases of treatment. And I want to tell you, all of you, that the evaluation is not one visit. Okay. I don't care what it says on your actual documentation screen, like the EMR that you're using, but the figure it out phase is still part of the evaluation. And in my estimation, that's going to take you, even an experienced person, 3 to 5 visits. And when you realize that, you can let go of a lot of anxiety of getting all of this stuff done in the beginning. All right. Now, I think it's still really important to get a picture of the core strength so you can plan for it. And decide where it's going to go, right? Is it going to go in phase 2 because you really do think that after your testing that it is part of a really fundamental why? Then it goes higher up. If you're going to do it in phase 3, we're going to get rid of all of the pain stuff and really prioritize a lot of other things, but we might add it back in phase 3 when we're actually starting to be able to move. And then we're going to go and retest all these things, right? And then, and then maybe you're prioritizing a ton of other stuff all the way until they're just about ready to leave. And you're like, you know what? Nicole Cozean said that I'm not allowed to let you leave here until we fully assess your core functioning. And so you're gonna do it in phase 4 because it hasn't been very clinically relevant this whole time. But I just want to dot my I's and cross my T's and make sure that it's good to go. All right. So this is what's going to help you to decide where that matters, right? Your clinical reasoning matters. The patient in front of you matters. The diagnosis matters and is a huge clue to where the clinical relevance goes. The symptom presentation matters, kind of like the example I gave with the person with dyspareunia, painful intercourse, where you found a positive core strength test. And it's just but the symptom presentation matters, how important is it? And remember that the core strength assessment will happen for everybody. It's just a matter of how, when, and where you're going to test it. Doing good on time, folks. All right. So how do we determine clinical relevance? We want to plan a core evaluation that makes sense given the symptom presentation, the diagnosis, and the patient desires. So this will be emailed to you afterwards. And it is where I want you to start thinking about the clinical relevance. So if you have a high clinical relevance, you're going to prioritize the core evaluation and core assessment into phase 1 of the plan of care. The diagnosis will sometimes be a huge factor in this, and then where the condition or diagnosis itself tells you it's high relevance. If it's low relevance, you might defer to a later plan of care. Other things about the diagnosis are of higher importance. And it's really not that big of a priority for the patient. And there's a little bit of I know it's a priority for us. Sometimes we really have to decide, is it a high priority for the patient? And it might be for us for a why perspective, but it's not for them to get stronger. You might have somebody coming in postpartum and being I really want to be able to do ab exercises. All right. So if there's anybody in this unsure category, that's where we want to test with some high-level screen to move them into a level so we can make a decision about these folks. All right. So this is what this kind of looks like. The high relevance people are really where core muscle involvement is in the pathophysiology of the diagnosis itself, right? This is the nature of being postpartum. Because of that slide that I put up, we know that there's going to be core muscle issues, right? It's hard to get out of that without having that. If someone has prolapse, SUI, diastasis, any other hernia, right? That's a pressure management problem in and of itself. The diagnosis tells you the pathophysiology, and therefore it becomes higher clinical relevance. Status post-pop surgery, prostatectomy, low back pain, pelvic girdle pain, anything in that realm is going to be higher relevance, meaning we want to do a more thorough core evaluation closer to the beginning of their plan of care, right? Now, conversely, if it's low clinical relevance, these are people like that have constipation, defecatory dysfunction, vaginismus. I'm not saying that core isn't important in these folks. I'm just saying that I've never met a person that comes in that has primary complaints and symptom presentation of constipation, bloating, difficulty emptying, defecatory dysfunction, where I'm leaving that evaluation being like, wow, if they only had some core strength, like all of that would go away, right? Now, I really do believe that there are some things with SUI, prolapse, like if we get that core system better, like almost all the things that you're describing will go away. I do think that for the people in those high relevance categories. All right. So that's where I sort of want you to go. Are we good with this sort of like depiction of that? And I put vaginismus in this category because I've never met somebody with primary, secondary vaginismus where I come away and they're coming to me for like a sexual health concern. They cannot tolerate a gynecological exam. And I'm like, here, let's go ahead and really do some wall planks and some sit-ups and some core movement. I might want to incorporate more movement in that person and I might want to incorporate more stuff, but I'm not going to come away from that evaluation being like, you know what, the first thing I should do is give that person some crunches. They really need to use their core better, right? Even if we know that they do have some core dysfunction, it's not going to be the primary thing that I go to. All right. Now, if we're unsure, and this is where it gets very interesting and really fun because we have such a fun job, you guys, people that have IC, BPS, penile neuralgia, some of these pelvic pain conditions are very interesting because sometimes it's kind of hard to know, like, is somebody that has penile neuralgia, sciatica, all that kind of stuff, like, is it important for us to do that or not? And this is where we're going to do a high level screen and essentially, for lack of a better word, figure out like how jacked is the system. And then that's going to help move us in that direction. All right. You guys know me a little bit. For those of you who know me, you know that's kind of my teaching style to be like, that's not very like scientific, but it is also because I feel if we could be like, how jacked is it? Then it's really not, we're not splitting hairs. It's either like, this is my next slide, right? It's either that it's, hold on, pretty good. Wow, better than expected. Meh, interesting, or yikes, that needs work. All right, so let me go back and show you how we're going to get there. All right, so how to screen for core eval relevance, right? So we're going to decide what screening test to use. What would make a good test in this category? We need it to be quick because y'all are going to do this probably in your first few sessions, if not the first session. It needs to be quick, it needs to be functional, it needs to be repeatable, and it needs to give one specific direction once positive, meaning it's going to mean something when we test it. Now, recall the strength components of motor control, load transfer, endurance, or capacity. In my opinion, a test in this category needs to do motor control and load transfer. It's going to give you the most information probably about how the core system is functioning to help you to decide if we want to go further test the endurance and capacity of it. All right. So remember to use the patient in front of you to pick the best test. Keep in mind their goals, activity levels, symptom presentation, and pain levels. I would love to leave it like that. I am going to tell you what I'm biased towards, but I really don't think it matters as long as your motor control or load transfer test is chosen at this time. So I personally like one of these three things. I personally use the active straight leg raise test. That's a Diane Lee thing. It's fairly repeatable. It is it's quantifiable, right? You're asking the patient from 0 to 5, I believe it is, what to rate like either their pain or how hard it was to lift their leg or whatever. I put in here a single leg squat because I know this isn't totally objective, but it can totally tell you about the motor control aspect and load transfer, especially from the ground reaction force up through the pelvis. And a lot of you basically asked me on the question, like, what about Sarman progressions? Is there anything else other than those? I mean, sure, they're also pretty darn good, you guys. And I think that, again, like they're kind of basic from a treatment perspective, like I don't typically use this stuff for, oh, now if you're bad at this, I'm going to give you this. I just use this more for like screening. And then I'm going to pick the motor control component that I'm going to look at and make up an exercise that's way better, that's going to take into account the person's pelvic floor dysfunction, back state, functional activity that they're going to get back to, and all the things. So I can't believe I'm saying this, don't tell Shirley, that I don't typically use this as like treatment progression, but I more use this, if I'm going to use it at all, as like a load transfer motor control assessment test. All right. Now, again, what to look for is screening tests. Overall, I don't care what screening tests you use, and I don't think it matters. I just want you to use one that you see fit, that you can perform well, that that you know what it's measuring and it's satisfied, like what makes a good test criteria. And then what you look for is the thing that can make it more objective, right? So do they hold their breath? What is their compensatory strategy to get this done? Does external support improve performance? Does a compression improve performance? Does cueing, a pelvic floor contraction or a transversus abdominis drawing in maneuver, or having them tense their upper limbs, does that improve performance of the test? If you're having them stand upright, does their center of mass shift? If so, how much? And I'm not talking about using like a freaking goniometer or anything like that, or like a measurement device. I'm just being like, mild, moderate, severe displacement, right? And then you're looking at recruitment pattern and the timing, the latency, the shift in the pelvis when you're doing, like, for instance, an active straight leg raise. So those are the types of things that can make it more objective and systematic when you are doing that test. All right. And if you think of anything, else that you have questions on, I have a whole like list here of things that I could let you know about in here. So whether or not it would be good. All right. Now, the 3 possible outcomes of this screen. So you have your patient in front of you. You're like, based on, they're in the unsure category for sure, right? And you're like, ooh, I don't really know if I'm going to like prioritize core. You do one of these tests. For me, that's the active straight leg raise test. And then I'm like, oh my gosh, that's way better than expected. I move it into like a lower symptom relevance to perform a more thorough evaluation. If I'm just like, meh, interesting, I usually will pick another test to try to get me to go to one of those things. And if I'm like, ooh, yikes, that's pretty jacked, that needs some work, then I move it to the more high relevance category. All right. So with all of that, now you kind of are like, cool. And then now if you have the people that are in the high relevance category, now I care a ton about all of their motor control stuff, their load transfer, their capacity to bear load, and their endurance of what they're doing. And I wanted to make it task specific so that I can do my further testing on that. Right. So if, for instance, I have somebody that is like has endometriosis and painful intercourse, and they've also been diagnosed with IC, they've got some MCAS, they're maybe a little hypermobile, I do the screening test and I'm like, yikes, that's bad. Then I'm moving them into the high relevance category. And now I'm more thinking about that. That might be the why for some of their pelvic floor muscle tension or something like that. Versus if that person was actually surprisingly good at whatever task I was having them do, because maybe they're more athletic or whatever, then I might, again, I'm not saying it's not important. I'm just saying it might not rise to the level of going into phase 2 or 3 for me. Probably phase 3, actually, more like phase 1 and 2. And I'm going to prioritize other things like sleep and whatever, you know what I mean? Like the foundations of pelvic health and all that stuff. Emily, I'll talk to you about that in a second. So putting it all together, now we have the framework. We're doing good on time. Here we go. And I will tell you the active straight leg raise test in a second. For who's familiar with the active straight leg raise test and uses it? Put me in the comments if you do. All right. Yeah, lots of peeps all the time. Good. So now you guys can be validated that it's legit, right? It's a legit tool. Now, I would be willing, of all the people that said me, are you real particular about this? Like it's supposed to be 20 centimeters apart from your legs, and you're going to ask them to lift 20 centimeters above. And then the cueing is very specific and all of that. So, yeah, good. Hell no. Not that specific. Okay. 8 inches should be somewhere. Okay. So here's the thing. If you actually look, I'm going to stop sharing here for a second and then I'll go back to this. For the active straight leg raise test, in my pelvic PT essentials, we're going to actually have demonstrations on how to do it, but I'm just going to describe it right now. You guys can just look it up, honestly. And of course, this is from Diane Lee. And I used to do it a ton. Then I got it because I took a course from her. I got away from it. And then I got back to it over the last few years, probably more like 5 years. And it's super awesome, you guys. I think it satisfies all of those things. It's repeatable. It's easy. All patients can do it because it's literally just like a lift your leg. And it's people for kinesthetic awareness, they can see what happens. You can easily show them a mirror for how much something shifts. They can feel it. You can ask them questions about where did they feel their body moving into the table. So for those of you who don't know, you have the person lying on the plinth, just straight. You're supposed to have their legs about 20 centimeters apart, and then you have them without any cueing of anything. And this is key. Because you want to see what happens with the timing and all of the things without influencing them. So how many times, you guys, do some people, you're like teaching them how to activate their transversus or do a pelvic tilt or something. And then there's a word for that. There's a word for, like, by nature of teaching them how to do it, you're altering the test, right? You're altering the outcome that you would get because you're already changing the thing. So the other good thing of a test is just to tell them, test them first before you teach anything. You've got to make sure you do that. And the bias is there because if we're too quick to be like, well, I'm sure it's weak, or they're doing like something, really a test bias. Like if you're doing something like really wacky, you have like the tendency to like jump in real quick and fix it. I'm way more interested into what they do and why, than anything else. And can I get them to change their strategy by adding on different things? And this is how you can get it a little bit more objective, excuse me. Right. Because if I always, with the straight leg raise test, do an anterior compression, a posterior compression, a pelvic floor contraction, and I'm looking for, shift and whether or not they're breath holding, right? Then now all of a sudden I just know to look for those things really quick, and I have on my EMR, I just have tick boxes for all that stuff. So I'm like, they did this, right? Improved with dink, 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 dink. So it doesn't even take me that long to write. And yes, so there's that. But sorry, laying on the table, feet supposed to be 20 centimeters apart. You lift. Yes, Carolyn, good job that you clarify that it's just a screen. They shouldn't go home and necessarily practice it. Totally. So you have them lift one leg. You say, lift your right leg. And I usually use my hand to my hand, and you don't tell them anything. And then they rate themselves on like how, if there's pain present, you say like, how painful was that? And if there is, this is where I modify it a little bit. If there's not, I say some sort of like, how much effort was that on a scale from 1 to 5 to lift your leg? And then I have them compare right to left. And then I just ask them a bunch of questions. What happens so I'm looking and seeing like what happens. And a lot of times it's like they'll arch their back, or they'll dig their neck in, or they'll do a significant amount of it's a little bit needing of like opposite extensor activity to like lift your leg. But if it's like really bad, or they're tilting, or their hip shift, then that's an example of like poor load transfer, right? And the load is essentially the lever arm of their leg, and how that's transferring up through their trunk, and how their trunk system and their core system is reacting to that, right? So if anyone has any other like tips and tricks about active straight leg raise test, I personally love it. Right, because it's a load transfer lumbo-pelvic stability. It's a supine leg lift at 20 centimeters. You compare sides. You can add compression, improve the force to see the force closure deficit, and the evidence strength is relatively strong in most of the literature that I've found. That's great, Rebecca. See, good. So I'm glad I use a piece of paper length as a standard height to raise their leg up. Perfect. Okay. So there's that. Are we good? Now I just got to finish a couple more slides and I will put it all together, give some examples, and then talk a little bit more about this long list of stuff that I specifically did not put in your guys' thing. And not because I'm trying to like withhold information or anything, but because honestly, like I don't necessarily think that all of these tests, we need to be doing all of them. I do think that it's good to be thinking about some of them, but I would just honestly, you guys, I would pick a few things that you tend to do. One capacity test, one endurance test, and one motor control load transfer test. And that's your battery of tests that you choose to do. And if those things become more positive, and if those things become something that you feel like your patient really needs more work on, then you can go down that rabbit hole with them, right? But if it's of high relevance, or if it's really, really, really important to the patient, then now you have a way to assess and then therefore assess in a more objective way for that. So let me just finish this and I will answer your question on which are my main go-tos. You already know the active straight leg raise one. Share. All right, so putting it all together, y'all. Now that we have a framework to use to decide when the plan of care we're further assessing and treating, right? Remember, motor control is the timing and coordination. I think it's most relevant in pelvic health, and it's most relevant from the literature standpoint of people that we're going to see that are in pain and or are pregnant or postpartum, because we know that motor control is one of the biggest things that changes. And endurance would be like a sustained contraction. That's what we do need for postural support. We do want this to be easy and getting the ability to do it longer. And I sometimes think of when do you need an endurance, like sustained contraction? It's like if you're carrying a kid, right? That's a little bit of load tolerance, but it is a little bit of a sustained, like if you're carrying a kid on one side, right, that wants to pull you down, you're actively using the other areas over a period of time to be able to not collapse, right? And so I personally think, and in the literature, this is where it gets interesting. Probably in the literature, the most one with strong evidence and that's most used is the Behring-Sorensen test, which is the posterior chain endurance test, which is a prone trunk hold off of the table. And I'm looking at my notes here. It's like useful low back pain risk profiling. It's very easy to replicate, which is why it's used in the literature a lot. But quite frankly, y'all, I don't think that that's appropriate for the vast majority of our patients. It might be for you if you have a super duper athletic population that gets off on that kind of stuff. But honestly, like I cannot imagine a person that's 55 with prolapse, GSM symptoms, C-section scar 40 years ago, maybe has some prolapse, and you're being like, get on the edge of my table and finagle around. I gotta strap your legs down. No thanks. But I think and a side plank test is also in that thing. It helps a little bit of capacity. So I usually for endurance type stuff will do more of like a bridge, a prone, like a plank, or on your knees or something like that, and just see how long they can hold, or a side plank if that's the appropriate. But side planks hard too, you guys, says me, who's a year postpartum, and I have pain when I do that. So so that's like something in that category. But, I want you just to think about, is endurance really important for you and for your patient, right? For a postpartum person, probably. But for, a lot of people, the endurance of just like living is kind of enough. Me struggling to try to demonstrate the actual test. I used to be like really good at that. And now I'm like, so here's this really cool video of doing it right. Oh my gosh. I like a bit one of those bear holds, like those bear crawl things. I like that, right? But that's not like, no, you won't find that on this test list because that's like not a thing. You know what? Honestly, you guys, if like an endurance test, like on, so a real-time ultrasound is another good example of someone in like the motor control, timing, activation. You can actually test transversus abdominis thickness. You can do bladder neck, talk about being objective. That's really good. I don't have one. I've never used one in the clinic. I think the learning curve is quite high. I've talked to Grania Donnelly a lot about whether or not, we all need to be moving to that. She would say yes. I would say probably eventually, but I'm going to go kicking and screaming a little bit. But for those of you who do use real-time ultrasound, it's a great other way to be able to do that. But it's not that quick sometimes, as I'm understanding. Maybe a couple things could be, but that's like a whole thing. So that's why I kind of like this quick screen thing. And to me, using real-time ultrasound would go in the category of like, what is like the more in-depth assessment if it's high clinically relevant, or you found that like, oh, that like looked jacked on the screening test. All right. So there's that. So, and then capacity for low tolerance, I either like just literally having them carry something and then just like observing. And this is where it gets like a little subjective, right? Observing displacement or observing how long they can do that before their form breaks or something like that. But I'm also really, and this could be a little bit in the motor control category, but I use it more for like load tolerance in the capacity thing. And it's very real world functioning for those of you, anybody in like IPA world, where the elbow flexion test, vertical compression test, and even the lumbar protective mechanism test are like really cool. So you guys can look those up. Again, like I ran out of time in like what I wanted to put in there, but they are really important and really cool. And I also got a little bit nervous, like not to do them justice when I'm just talking about them, because they are pretty particular on like your hand holds and your cues and where you stand and how you're applying the force and stuff like that. But if you're interested in doing that, and I'm not affiliated with the IPA at all, but they're really cool testing things. And so, but basically it's you have your patient standing and you're like standing in front of them on your knees and you're having them hold. So you're having them hold their arms like this, as if they're like carrying something, right? And then you are below them. Like, so now you're on the floor. This is where their elbows would be. And you are like applying a force straight down to see what happens with like how much they turn on their ability to withstand the load that you're placing. So of course, right, we lose some objectivity with my how much of force am I applying and all of that kind of stuff. But that's where I like putting my hands on people, and I can actually feel sometimes someone breaking. I can feel where they're strong and then where they buckle first and that kind of stuff. I personally use that for my load tolerance capacity stuff because I do think it's real world functioning. And Carolyn, it's the lumbar protective mechanism. That's where you're standing like kind of diagonal with somebody. So you are standing like with this is my sweat. I'm in my sweatpants, guys. Thank goodness I had pants on. That's great. So you're standing like staggered stepped with your patient and you're really close to them. And then you're putting a little bit of applied pressure straight into their shoulders, and you test in both stride configurations, and you're seeing like where they lean back, and then you can see like all of that. I will type them right here. They're called the lumbar protective mechanism. It's the advanced lumbar protective mechanism, elbow flexion test. And what did I say? My brain just turned off. I'm like, I'm done. Yes, vertical compression. That's like, what does gravity do to you? And so it's like the old world PNF balance testing. Yes. So I personally like that. Other things on here, I'm just going to go through what these other things are. Some people like for like control, like motor control, like just doing a bird dog and doing an opposite arm and leg lift and seeing like what happens if you lift your leg and do you go down. It's a great real world function carryover, especially if you're, the evidence for that is strong, is moderate. A single leg bridge is another example of like where you can really do tilting and where do people start to overcompensate? What happens with a breath hold there? Does it get stronger? Does it get easier? You can sometimes see like delay, stuff like that on things. But honestly, the Sarman core stability tests, and the Bearing Sorensen test, that's the prone thing off the edge. Like it gets really high scores and stuff from like a objective measure and endurance and capacity thing. But like, honestly, like I haven't done that. Yeah, Monica. So here's the thing. I personally just like do the active straight leg raise test as like my screen. And then I'm looking at the person and what they want to do. So if they, I actually put it in here. Interesting. You forget what you do when you're a procrastinator. So this is the kind of stuff that is on here. This is stuff we're going to go into a ton in the essentials and like, what is all this stuff and do we care about it and all of that. But yeah, like bridge marches in here are like, basically that's like a single leg bridge is that. So you can watch for pelvic drop and rotation. It's moderate. It does do posterior chain and pelvic control. So it's more of a like motor control capacity kind of thing, which is good. I mean, if you love doing that one, then I would do that one. Not all my patients. This is where it's like important for you to know where I came from. I came from somebody that is like a lot of really chronically ill and chronically people in chronic pain. So yeah. I even put this in here. This is so wonderful. Okay, so I have active straight leg raise. It does have some objectivity to it. You set up and rate all that. I personally like this one. I should have put a star by it. You could use Starman progressions. If you're using those are very good. You could use a blood pressure cuff underneath them. And the objective portion is that, plus or minus 10 degrees of change in the blood pressure cuff reading is what makes it more objective that way. That is what in the research shows. That's a lot of like the research stuff. I used to use that a long time ago. I got moved away from it because I feel like even something as simple as that, like the setup and stuff like that. And now you're cueing the person and they don't really know what you're looking at. And I personally don't love that for this quick screen test stuff or for other in-depth. I think there's better. I like the ASLR better, but whatever, you guys, this is where I don't want you to treat exactly like me. I just want you to understand what you're using and you can make it more objective by systematizing your own assessment, right? Load weight for capacity measurements that you can like actually make more objective and like perturbation. Are they doing it on, that's where you can like, how much displacement was there with certain things. And then I like plank holds for the endurance piece. The objective portion is baked into the test and then you just do time and then there's like norms for time and stuff. So I like that. Perfect. All right. So I have a few minutes here. We are done. Q&A. So why don't we do this? If you have any questions, put them in the chat. Thank you so much for attending. We are going to go through, I have a few more minutes. I'm going to do some of these clinical applications so that we can start to think through some things by using this framework and like deciding what to do. But I just want to thank you so much for spending time with me today. You can always follow at Nicole Cozean DPT. That's my Rising essentially account, which is mostly clinical and business. And so we do that. You can listen to the Pelvic PT Rising podcast for more stuff. And pelvicptrising.com/clinical is all my clinical stuff. I have 4 full-length courses, 3 master classes, and Pelvic PT Essentials is getting revamped in a big way. And it's going to be really cool, if I don't say so myself, because this is basically like one part of one module in like it's going to be a beast, you guys. So okay. Here we go. So keep doing these questions. I'm going to run through a couple of these just to like quickly show you how this framework would work. All right. So a person who's 8 months postpartum, a runner with incontinence. Okay. Automatically. Oh, I just froze. Automatically, by the nature of being postpartum, having stress urinary incontinence, and being a runner, which has a lot of motor control, a lot of endurance importance in there, and not as much load, but a lot of load transfer up through the ground reaction force, controlling motion, all that. So that obviously makes it a high relevance. The core system is highly relevant. And you could do an active straight leg raise test on them, but you already know that it's going to be very important to test like load capacity and motor control. And I would even argue endurance. So I would do in-depth testing on all of those ones, and I'd watch them run. I mean, don't forget about that, right? Watch them run, but we're not really talking about like core muscle testing in that. I still don't forget that you can also just like watch them. And I think we're not that far away, honestly, from like doing that and, having AI analyze their run and like looking at how much, vertical displacement is there and all of that stuff. So I think that's interesting. So can contrast that with someone like you have endo and painful intercourse. That's in the like by the pathophysiology of the condition alone. I'm like not totally sure how much the core is involved in their whole system. We know that it's because they're in pain, we're expecting it to not be great, but that's why we do the active straight leg raise test. It's very easy. It's very approachable to these folks. And then we can use the thing where it's like, if they do kind of good on it, you're just like, wow, like cool. Do I still want to incorporate core stuff in their plan of care? Sure, but I'm going to prioritize other things. Because with this person, they have painful intercourse. If I had a person that was with endo and they wanted to get back to rowing or something like that, then then that changes where the relevance goes, and if they suck at the test, I'm like, we might need to do that, but I'm not going to do it right away because there's tons of other things that we need to do. You came in for painful intercourse. Let's address that. And then as you get into phase 3 and 4, that's when you're going to do more of the assessment tools, right? I want to do someone with premature ejaculation, penile pain, and femoral hernia. That's like I'm not sure where that person goes. So to me, the femoral hernia is interesting because it might move them more into the pressure management issue. And that might be disrupting a nerve in that region, right? So you have to use a little bit of clinical reasoning. For me, I would probably put that person into an unsure category. I have them do the quick screen and they're, not great at it. Then I put it more into the higher relevance category. Or when they do the active straight leg raise test, their penile pain gets worse the worse the test is, and maybe doing a breath hold or a compression of their pelvis, their femoral hernia either doesn't come out as much or it's not as painful in their penis or whatever. And I'd be like, ooh, cool. Now that is high relevance. I'm feeling like maybe some of the core muscle activation strategies that you're using are perpetuating that penile pain. Now we have a higher relevance where we put it more into the thing. And now we do more core stuff with them. So let me hit some of these questions. Okay. When do we take into account core muscle imbalances, IO versus EO, rectus versus TA? I mean, do we try to cue for that to have a more symmetrical contraction? I know that there's some people that are a little bit over, very hyper focused on external oblique. They're gripping with their obliques, right? Overactivity. I understand that, but the whole point is that we work as a system. So like you can't not contract. You can't be like, I'm only going to contract the rectus, right? And I'm not going to contract the TA at this time. And I'm going to isolate those things out. So I don't like trying to figure out all of that stuff. I'm more looking like, does it matter? Like, what does a person look like when they're doing it? And does some of those things that you might be seeing, does that mean that there's a delayed in timing with them turning on when they have a load on them? Does it create a system where they're pushing their thoracic spine down into the table and increasing pressure downwards when they're trying to do that? Does the strategy cause the problem? Because I will say, like, if once we start to really like look at muscle imbalances, we're forgetting that sometimes that's a compensatory strategy that is there because of something else. And that's what I think that we really need to do like a deeper dive on. I hope I'm making sense with that. So I don't feel like the goal is ever to have a symmetrical contraction. I'm thinking that does the timing, does the activation, are they able to take load, and are they able to move through life with varying levels of intra-abdominal pressure, load, and breath? That's what I care about for this. So Erica, I hope that makes sense. So the other, yeah. Thank you so much. Love the way you communicate. Thank you so much. Brenda, would you recommend waiting to take the Revamped Essentials course? I will tell you this, it's going to be great. Anybody that has purchased it before because the price is going to go up because it's such a big course and it's such an improvement. But if you buy it now, you're just going to get access to the course when it's updated for free. So if you are one of those people that Essentials is like on your list, I would personally get it now because you're just going to get the revised course for free. But if you wait to do it when I actually launch it, I'm going to raise the price. So just to be honest. Early postpartum, yes, I would still totally do active straight leg raise tests. And I think that for that population, early postpartum, they're doing more stuff than that anyways. And I think you can really start to see some deficits. Sometimes I think that we're not as bad as you think they're going to be, right? And you can really see like where their strategies are. So like, are they breath holding, or are they co-contracting and bracing too much, or are they using their arms when they're doing it? Like, that's where I really feel like it can give you a lot of insight into other aspects of their stuff. Revamp is going to come out. I thought it was going to be late May. It's probably going to be more like June, to be perfectly honest with you guys. I'm working hard and then life. So, but for sure, summer. Okay. What else? Okay. Anybody else have any other questions, concerns, thoughts on this? I have a few more minutes here. Awesome. Anybody in here disappointed that I didn't like just go through all of these? I thought about that and I was like, that's boring. And not all of these tests are relevant to you guys. So yeah, and that's another big thing. And this is kind of what I'll end this on. I just think that This is the big difference between when you're looking at something that's valid and specific and sensitive and blah, blah, blah. Like the stuff in the research is really not always applicable to real world clinical practice. And so when I'm doing a deep dive on the research and things like the Bering-Sorensen test keep coming up, I'm like, right, but like, I'm never going to do that effing test, you know? And so, that's, I feel like, the frustration. And quite frankly, I feel like that's what you guys are paying for when you're taking like one of my courses or whatever, is me to like actually synthesize the information and then also apply it to our patient populations. Because I think that pelvic especially is just a really cool area, but there's just a lot of nuance to the types of patients that we treat. So even somebody that's doing chronic pain and like low back pain or pelvic girdle pain isn't going to have the same insight into like, does that actually going to work for a patient with like vaginismus or vulvodynia? Like I know those types of people that come in, and those are the people that freaking shut you out if you start talking about their core strength, because like, you know, or if you don't talk about their core strength for someone that has diastasis and is really like obsessed with like getting their core function back, and you're like, well, let's look at your hip mobility. I'm like, I would prioritize the core stuff way more if they're into it and you know that they have high clinical relevance, that it's going to be important for them. Do you know what I mean? So that's where I really feel like I hope that this was helpful in applying some of these things that are usually talked about in orthopedic realms and whatever, and we're applying them to the pelvic realm because these are the patients that are going to come up to you. I would just like to know if you schedule the eval patients the next day or you wait until the next week. Logistically, we have 1 hour appointments and 2 hour appointments at Pelvic Sanity. So I usually I call it the last 10, which I teach in the essentials. In the last 10 minutes of the evaluation, I'm summarizing what we found that day. And I'm also telling them what the figure it out phase is going to look like, what we still have to get to. So the real world example of somebody that I'm like, I tested active straight leg raise test maybe that first day. And, I'm actually like, oh, I do want to look at this core muscle test like stuff a lot more. I'm saying, this is what we found today. You know, you did perform this way on this test. That tells me X. When I gave you a little bit of compression, your pain went away, or your pelvic floor seemed to relax, or whatever. And so I do next time want to really give you a little bit more challenge to that core system and see really where we are in there, and to see like how I can tailor some of these exercises for you. So they're not going to be boring. You're going to want to do them, and they're going to be really relevant to your whatever they came in for: stress urinary incontinence and diastasis, right? So I'm usually doing if I'm making this is highly relevant and they sort of sucked at it, and or then I'm usually putting that in the figure it out phase. And if not, then I'm like, we're going to get to that when we get to it, but we need to talk about your sleep, or we need to talk about something else, or your nutrition is all over the place. It's a whole nother deal, right? I'm gonna. This is really good. I have a few more minutes here, guys. If any thoughts of any tests that you would do, you would defer or definitely do or skip if your client is significantly large. I find that with very overweight or larger body clients, it's harder to discern some of these tests just because of body size. That is true. If that makes sense, for example, they barely know how to do a squat, a single limb squat with any. Right. So if someone has a larger bodied person, that's why I kind of like straight leg raise test. That's why I also like vertical compression test. Vertical compression test, elbow flexion test, lumbar protective mechanism, because it's very obvious where they break or where they want to tend to grip or whatever. So yeah, I would do a little bit more functional, just standing stuff. You can also do a vertical compression test sitting, and you can do an elbow flexion test sitting. They don't really have to like move around that much. So I would still probably just watch how they move, but not put that in the actual like core assessment strategy. Blah, 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 blah. Cheryl, if you bought it a month ago, then cool. Then I mean, it's not bad the way that it is. It's awesome, but it's just going to be even that much more awesome. So you'll just get the updated version. Okay, I think that's it. No, did I miss anybody's? If anybody, oh, it's past midnight here. Thank you for staying awake. Check out those tests, refresh my memory. That's great. Any last minute questions that I've missed? Capacity test with perturbation. I feel like it was motor control test with perturbation. You could just do a capacity test, so like a load, and then like make them have a perturbation or stand on an unstable surface with that same load. So that was an example, Daniela. And then the other thing that I sometimes will do, in addition to the straight leg raise test, because that's like load for the lever arm of the leg, I'll also have them lay flat, put their arms up in the air, and I'll do perturbation testing in different planes from their arms and see where they shifted their pelvis when you're doing it in the transverse, frontal, or sagittal plane for there. Diana, you're welcome. Perfect. Can you talk more about upper versus lower abs and if it matters? I hear this often, but I also feel like it's not very functional. To be quite honest, Monica, I personally don't care about it unless it's like crazy obvious. Because they function in a system, I I I know what you're talking about with like upper ab gripping, and this is where it gets like a little bit interesting with like rib flare kind of stuff. I know that there are some people that are really into correcting a rib flare, because of the length tension relationship that it has, with the obliques, especially. Um, Quite frankly, I feel like sometimes that's good, and sometimes it gets us down a rabbit hole of fixing something that doesn't necessarily need to be fixed, or fixing something structural that really in real life doesn't matter as much. So I do know that like post-pregnant and postpartum people tend to, I mean, there's morphology changes in the obliques, especially external obliques. They get thinner because they had to, and so they don't work as great. So, and sometimes that can create a rib flare, but I don't really talk about like trying to like, oh, turn on your lower abs. I'm much more about, let me get those things to turn on automatically. So I'm much more interested in load carrying and asymmetrical things and resistance bands. And that's all in like my essential pelvic strengthening class, because I feel like it matters like what kind of actions they're doing at home and stuff like that. But I don't feel like I've ever really been like really trying to train the lower abs like I used to like 20 years ago. I used to be obsessed with the transversus abdominis and all that, like turn it on and it's got to be on in order for us to have good core strength. And that's just like not how the core works. And if it's supposed to be anticipatory, we need to like train it to be anticipatory and automatic. And I don't think that volitional stuff really does it for me. I do think that we need to take it into account of biasing something. So I might, if I have somebody that I think that might be a thing, I might have them fix their arms so that they can't have a lot of degrees of motion up here. So I might have them do a lot more like weight bearing through the arm stuff to sort of help that. And now I'm doing like bear crawls and bear holds and that kind of stuff. And then typically you retest that and it's better. Instead of being like, I'm going to fix your rib flare so your abs work better, I'm like, let me get your abs to work better in a posture where it's really hard for your ribs to do what I don't want them to do. So that's where I go with that. So good question. And I'm glad we got to that one. All right. Still 125 of you on. I'm so happy, you guys. This is so fun for me. This literally gives me life. Thank you so much on a week where it's like been really hard at home and stuff like that with our kids are both sick. And I just really thank you guys for making this fun. This really like gives me life to be able to do this, and it makes me so excited to continue to do the Pelvic PT Essentials relaunch. If you guys have any questions about that, you can always DM me. I really appreciate you all. Thanks so much, and hopefully you guys will use some of this framework and superimpose some of the stuff that you're already doing, and fitting it in so that you can treat your patients better. I mean, that's what it's all about, right? Continuing to be better. So let's continue to rise.